About 3 to 4 years ago, there was a great hype about immunotherapy, and this is an example of an editorial from the New England Journal of Medicine, releasing the hounds that have the T-cell response to cancer. And this was, the reason was that we have found a way to do that. And this is by the inhibition of the PD-1, PD-L1 pathway. If you have a tumor cell and a T-cell, normally the T-cell is able and capable of killing the tumor cell. But if the tumor cell exploits PD-L1, this will contact PD-1 on the T-cell and will attenuate immune response. This mechanism is very, very important for us to prevent us from hyperimmunity, but it's fatal in this kind of pathway in cancer. So the kind of treatment that was developed was antibodies to either PD-L1 or PD-1 to interrupt this pathway. And it could impressively be shown that by doing that, the T-cell is again able to destroy tumors. Well, what about clinical data? We have many data on stage 4 disease, but we also have data on stage 3 disease. And this is new, and there was some data shown on the ESMO this year. In the PACIFIC trial, patients with non-small cell lung cancer received chemoradiotherapy as a curative treatment. After this, they were randomized to receive either the PD-L1 antibody durvalumab or placebo for a duration of 1 year. The trial had 2 co-primary endpoints, which were progression-free and overall survival. At the meeting, the first endpoint was met, and that was progression-free survival. And you can see that those patients receiving durvalumab had an impressive better response and progression-free survival than those on placebo, culminating in a hazard ratio of 0.52. And this is indeed a fact in all subgroups, maybe with one little exception. If you look at the EGFR positive patients, there's a little less benefit, and this is what we know also from trials in stage 4 non-small cell lung cancer. Again, very impressive is the fact that the durvalumab arm had significantly more responses even after finishing chemoradiotherapy than those patients on placebo had. Moving to stage 4, we had some very interesting results from early trials. In this trial, there was PD-L1 measured in the tumor as an immunohistochemistry test. And if in the tumors the PD-L1 expression was higher than 50% of cells, you can see in this Kaplan-Meier curve a very impressive survival curve we have never seen in thoracic oncology before. Well, this is a very early trial, but it was the reason to perform the KEYNOTE-24 trial, which is a randomized phase 3 trial, which was presented on ESMO last year and an update on the World Lung Cancer Congress this year. In this trial, patients with non-small cell lung cancer who had a PD-L1 expression of 50% or more were randomized to either receive the PD-1 antibody pembrolizumab or a platinum doublet chemotherapy at investigator's choice. Very important is the fact that patients in the chemotherapy arm were allowed to cross over after progression, because the endpoint of the KEYNOTE-24 trial was progression-free survival. Here you can see that in the chemotherapy arm, the blue box, about 2/3 also received immunotherapy as a subsequent line of therapy. And although that happens, there's still an ongoing, very significant and relevant benefit in terms of overall survival for those patients who received pembrolizumab in the first-line treatment. And what we achieved for the first time in this kind of population, which is about 30% of all non-small cell lung cancer patients, is a median overall survival of 30 months, which is a very impressive result. And even more impressive is the side effects profile, which you can see in this slide, where you see that the side effects with pembrolizumab are almost always less severe than with chemotherapy, with the only small exception of pyrexia. And also the appearance of grade 4 side effects, which are the striped boxes, are less than with chemotherapy. The sister trial of the KEYNOTE-24 was the CheckMate 26. It was about the same design and about a very similar drug. Nivolumab is also an IgG4 PD-1 inhibiting antibody. So it's very similar to pembrolizumab. And also the trial design, as I said, is very similar to KEYNOTE-24, with the exception that patients with any PD-L1 expression could participate. Well, the very surprising results were that there was no excess benefit of the immunotherapy in terms of progression-free survival and also not in overall survival. And in this cohort, only patients with PD-L1 expression higher than 5% was considered. And even if you look into the cohort of high-expressing patients, those with more than 50% of tumor cells expressing PD-L1, there was no excess benefit for immunotherapy. To date, nobody can really tell why there's such a huge difference to the KEYNOTE-24 trial. Well, maybe the problem is that PD-L1 is in this trial not the right biomarker. So what was done in this trial was that they looked at the tumor mutational burden, which is nothing else than the ratio of mutations in the whole genome. So the probes that were available, were about 2/3 of specimens still available, were looked at. And then there was terciles built. Lower than 100 mutations was called low mutational burden. 100 to 242 was called a medium tumor mutational burden, and everything from 243 onwards was high mutational burden. And if you plot mutational burden against PD-L1 as potential predictive biomarkers, you see that you have some kind of a cloud. There does not seem to be a real strong correlation between those two. But if you look at the progression-free survival curve retrospectively of the CheckMate 26, you see that those patients who had a high tumor mutational burden and a high PD-L1 expression had the best results. But even more striking is if you look at the green lower curve, you see that there were patients that had, although they had a very high PD-L1 expression, they had a low tumor mutational burden and they had the worst outcome. So this is maybe the reason why CheckMate 26 became negative. We now have 3 drugs in place, which is nivolumab, pembrolizumab and atezolizumab. They were all tested in large phase 3 trials. They were the CheckMate trials for nivolumab, there was pembrolizumab in the KEYNOTE trials, and atezolizumab in the OAK trial. The comparator in all trials was docetaxel, a standard chemotherapeutic agent which is frequently used in second-line treatment of non-small cell lung cancer. The subsets of the trial were quite a little different. In the CheckMate 17 trial, it was restricted to squamous cell lung cancer. In the CheckMate 57 trial, it was restricted to non-small cell lung cancer. The KEYNOTE trial only enrolled patients with any PD-L1 expression, meaning more than 1%. And only the OAK trial was a so-called all-comer trial, meaning that all patients with non-small cell lung cancer who had one prior treatment could be enrolled. You see that the numbers of patients were quite high in all trials, especially in the OAK trial. And we saw that we had very impressive results in overall survival with the immunotherapeutic agent, ranging between 9 and 12 months plus. And we see in all trials a very highly significant benefit compared to the comparator docetaxel. These results led to the approval of all 3 drugs in the EU, with a little exception that pembrolizumab is only approved for patients with any PD-L1 expression. PD-L1 negative patients are excluded from pembrolizumab second-line treatment. Very impressive for me is that we now have the first 5-year survival results generated with nivolumab from an early phase 1 trial. And as you can see, there is, depending on PD-L1 expression, a 5-year overall survival rate from 20 to 43%. Please keep in mind that in epidemiological data, we are coming from 0 to 10%. Of course, I know these are very few patients. Now have a little closer look on these patients. What you see here is the blue bars denote that the patient is under nivolumab. The yellow bars denote that the patient is alive, and the arrow denotes that he's still on study and still alive. And what you can see that almost all patients had only 2 years of treatment with an ongoing response afterwards. What you also see is that the patient does not have many subsequent therapies. Only very few were denoted. Why is that? The reason is that this population of patients was heavily pretreated, with every arrowhead denoting one regimen of chemotherapy. So this makes these results even more impressive. We're talking about third line, fifth line treatment and have such very meaningful 5-year overall survival rates. And this is what we hope to achieve from immunotherapy. Maybe response is not that much better than with chemo or targeted therapy, but we want to have more people alive in the later years. What we mean by the tail of the curve has to be risen, like it is seen in this slide. So in summary, if we talk about immunotherapy in lung cancer, we talk about checkpoint inhibition to the PD-1, PD-L1 pathway. We have now a standard of care in patients with more than 50% of PD-L1 expression, as long as they don't have an activating EGFR mutation or ALK rearrangement, and this is monotherapy with a PD-1 antibody pembrolizumab. The PD-L1 axis inhibition has a broad indication in second line. It could be given virtually to all patients, where there's some who might benefit from other kind of treatments, but from the point of approval you can use nivolumab, atezolizumab in all patients and pembrolizumab in those with any PD-L1 expression. What is the future? What are the next steps? Well, we are heading for phase 3 results for combination therapy of chemotherapy with immunotherapy, or immuno combination, or for example, combination of immunotherapy with anti-angiogenic agents. But by now, we already have impressive results in this field of lung cancer. Thanks for your attention.